Hi everyone, today we will speak about the forearm fracture. Accordingly, we will speak about the functional anatomy of the forearm, definition of the fracture, mode of trauma, diagnosis, management, complications, and special entities of this fracture. According to the functional anatomy, the forearm is formed of the two bones forming this segment, which is the radius and the ulna. The radius is more lateral and the ulna is more radial. You can see both of them are connected together through three connections, proximally through the proximal radio-ulnar joint, where the head of the radius would be present within the radial notch and connected together through the annular ligament, distally through the distal radio-ulnar joint, where the styloid ulna will be present within the sigmoid notch of the radius, and between them there is interosseous membrane. This interosseous membrane is the strong fibrous sheath connecting both bones together and help in their motion. What's the motion which is more important here? What's the motion which is formed by forearm? It's supination and pronation. And to help the motion to occur, we have the supinator, which is present proximally in the proximal third of the forearm, and distally we have two pronators. The pronator quadratus, which is the most important, which is present between which covering from the ulna to the radius more distally, and we have the pronator teres as an association. So we have supinator for the supination and the pronator quadratus for pronation. What's the forearm fracture? This is the fracture of one or both of bones forming the forearm. This area includes the following: all of the ulna except the olecranial styloid ulna, and all of the radius except the distal ends of the radius and the head radius. You can see here through this photo, this is the forearm bones, and this box represent only the area where the fracture occurs. We call it both bones, or the shaft of the forearm fracture. What's the trauma causing this fracture, or the mode of trauma? We have two modes of trauma. Either we have what's called direct trauma. In the direct trauma, this is created by the direct impact to the forearm causing the fracture, like hit and strike or during a fight. It requires high energy trauma, and mostly it will result in transverse or comminuted pattern. In indirect trauma, we have like something like pulling an outstretched hand or rotational injury. And of course, indirect trauma means that the trauma would be present away from the site of the fracture, not like the direct trauma. So here in the indirect trauma, in the case of rotational injury, in the functional falling of outstretched hand, this is the more common, and the rotational injury, which will result later on what's called spiral fracture pattern, it may occur through high or low energy trauma. How can we diagnose this? We have the following. First of all, the symptoms. The patient will come complaining of the following. Firstly, he had to say to us a detailed history of the trauma, the type of the trauma. The patient also will have a pain in the forearm, swelling of the forearm. The swelling may be generalized and localized. Presence of the deformity. The patient should complain of a certain deformity of the forearm and inability to use the affected limb. According to the signs, or what's called by the examination, we found that the injury site is tender. There will be swelling either localized as a result of the hematoma or the bony ends, or may be generalized, for example, due to compartmental syndrome. There may be discoloration as a result of the hematoma, extensive hematoma present underneath the skin. And for the neurovascular examination, we have to look for the radial and ulnar artery. We also look for the median nerve, the ulnar nerve, and the posterior interosseous nerve. Honestly, the nerve injury is not so common. If we have to look for the posterior interosseous nerve, it occurs only proximally, not distally. The ulnar nerve and the median nerve requires high energy trauma or even open fracture to occur. According to the radiological, of course, we are doing plain X-ray with the two views, anteroposterior and lateral view. The importance of them is to detect the following. First of all, it's single or both bones. Either one bone is affected or both bones are affected. The level of the fracture, is it upper third, middle third, or lower third? Also, is it displaced or not? And to describe this displacement, displaced proximally and dorsally, volarly, shortening, rotation, angulation, and so on. Here, also for the skeletally immature patient, we have to look for this green stick fracture or not, and also to detect the fracture stability, either this fracture is stable or not. So, according to the fracture stability, the stable fracture occurs in green stick fracture, the transverse fracture, or the fracture at different levels of both bones, while in the unstable fracture it occurs in the oblique fracture, in the comminuted fracture, or fracture of the both bones at the same level. So at the same level will result in unstable fracture, while the fracture of both bones at different level, it will be more stable. Here is some sort of the training. This is a plain X-ray with the anteroposterior view and lateral view, the right side of the skeletally mature patient with no abnormal soft tissue shadow in the scene. Also, it shows the forearm, the wrist, and the elbow, and you can see the fracture, which is upper third of the radius. It's isolated fracture radius upper third. Here, there's minimal displacement, even I'm sorry, in the ulna, and the displacement is less than what's called radial displacement because we are describing the displacement according to the distal fracture. Also here, this is another exercise. This is the plain X-ray, the anteroposterior view. Only the anteroposterior view. This is the skeletally mature patient. Of course, we can't detect the site. Also, you can see this is the forearm, wrist, and the elbow somewhat. You see that this is the fracture of the both bones, where the upper third of the radius, which is transverse, and lower and the middle third of the ulna, which is some sort of oblique fracture. And we have what's called ulnar displacement because the distal fragment of the radius is displaced to the ulnar side. Another photo. This is the plain X-ray and anteroposterior lateral view, of course, of the skeletally immature patient with the forearm, wrist, and elbow. And which see here, you can see the fracture almost in the what's called upper middle third, with the presence of the volar angulation as displacement. The last one, this is the plain X-ray anteroposterior lateral view of the left side of the skeletally immature patient, shows the fracture in which there's shortening. There's in the anteroposterior view there's shortening, there's overlapping, and there is of course in the anteroposterior view there's ulnar displacement, and in the lateral view there's dorsal displacement, so it's displaced dorso-ulnarly. How to manage this? According to the patient age, is the management will be decided. First, you have to see in the skeletally mature patient, always look for the operative treatment. The skeletally mature patient or adult, we have to look for the operative treatment, while the skeletally immature in the children, either conservative or operative. When we go conservative, in the following. Firstly, in the green stack fracture, there is no need to do operation. Also, in the case of the fissure fracture, undisplaced fracture, in the stable fracture, and we knew the criteria of the stability from before. How to go conservatively, the method of treatment differs according to the number of the bones affected, either single or both bones, the level of the fracture. Also, the treatment algorithm will speak about the single fracture or what's called isolated fracture radius, ulna, and then both bones. So, in isolated fracture ulna, always above elbow cusp, whatever the level. In isolated fracture radius, according to the level, if it's lower third, so we go to below elbow cusp. In the middle third, above or below, and it's better to be above. And in upper third, there's above elbow cusp. In the both bones forearm fracture, always above elbow cusp. And when the both bones are affected, we have to go above elbow. The ulna is already broken, so we have to go above elbow. However, the fracture of the radius, the level of the radial fracture, will identify the position of the hand where we will put the cusp. Means that if the fracture is present in the lower third, we will go to above elbow cusp in pronation, while in the middle third radius, above elbow cusp in midway, and in fracture associated with upper third radius, above elbow cusp and supination. We have to ask ourselves why. Because in case of the lower third radius, the main deforming force is pronator quadratus muscle. So we have to rest the fracture, not to displace, so put in the resting position, which is in pronation. So in the lower third radius, the fracture should be, and the cast should be in pronated position, above elbow cast in pronated position, to avoid deforming force of the pronator quadratus. While in the upper third radius, we have to put it in supination to avoid deforming force of the supinator muscle, which is very important. This is the photo for cast. This is the above elbow cast in midway, which is on the left, and on the right, this is in supination. According to the operative treatment, it can be done in the fracture in the mature patient, whatever the level and whatever the displacement, in a skeletally immature patient in unstable fracture, or in the lower third. And in case of the lost reduction after conservative treatment, the patient was stable, we made conservative treatment, we made above elbow cast, however the patient displaced later on, so we have to look for the operative treatment, not to do conservative again. How to do operative? We have some certain modalities. The first modality is closed reduction and intramedullary pinning. This can be done by closed reduction of the fracture under C-arm guidance and fixation by intramedullary pinning. This can be used for skeletally immature patients. This is a photo showing the patient with two intramedullary wires, one for the radius and one for the ulna, for fixation of middle third transverse fracture, both bones. The other modality is open reduction and plating. This can be done by exposing the fracture and fixing the bones internally by plate and screws. This can be done for adult children above the age of 10 years. When we are going to do fixation, you can see here this is the fixation by both bones or both bones by plating. The last thing is to do the external fixation. Open reduction and external fixation can be done for the management of the open fracture and management in the case with infection. This is a photo for the patient who had external fixator and it's presented mainly on the ulna. What are the complications we have? The first complication what's called radioulnar synostosis. This means there is cross union between both bones. Here, both bones are united and the interosseous membrane making instead of the being fibrous membrane to be a bony membrane between them. Mostly occur after doing single incision or to have screws during plating. The screws are so long so it will injure the interosseous membrane. It will result in loss in supination and pronation motion. This is the photo of the patient who have cross union, what's called radioulnar synostosis, which is present in the middle third. The second complication is malunion. When it's malunited, means that united in undesirable position, and of course, non-union may occur if untreated. This is the patient with the malunion in the form of ulnar displacement and dorsal angulation. Post-operative infection may occur, and at last, compartmental syndrome. In the compartmental syndrome, this means increased intracompartmental pressure to be more than 30 millimeter mercury because of the extensive hematoma inside the forearm compartments. In this condition, if untreated, the patient will go into Volkmann ischemic contracture. Speaking about entities, we have two special entities, what's called Galeazzi fracture and Montague fracture. Beginning with Galeazzi. What's Galeazzi fracture? The definition, this is the fracture of the lower third radius with the disruption of the distal radioulnar joint. We can remember now that both bones are connected together proximally and distally, and midway, proximally by proximal radioulnar joint, distally through the distal radioulnar joint and the interosseous membrane. So, in the case of the fracture of the lower third radius, alone or isolated, there will be shortening, and so the distal radioulnar joint will be disrupted. According to the radiology, you can see in the anteroposterior view there will be shortening of the radius with the widening of the radioulnar joint, while in the lateral view, as in this photo, there is dorsal angulation, there is shortening of the forearm, there is dorsal displacement, very important, dorsal displacement of the head of the ulna, which needs urgent treatment. How can we treat this patient or the management? No conservative treatment for Galeazzi fracture. No conservative. Always operative. We can do through open reduction internal fixation by plating, which is very important because in this because in this condition we are regaining the actual length of the radius, and of course we will regain the actual length of the forearm. And then we will assess the distal radioulnar joint through assessing the head of the ulna, either it's displaced or undisplaced, stable after reduction or not. So if it's stable, replaced or what's called reduced and unstable in its place, nothing to be done. However, if it's unstable or irreducible, then we have to do reduction and making radioulnar wire and then put the patient in above elbow cast in supination. You can see here, this is the patient after Galeazzi fracture, and then we have reduced both the ulna over the radius, and you can see now two K wires, even not one, are introduced from the ulna to the radius to reduce the head of the ulna, to reduce the head of the ulna into the sigmoid notch. The second entity is Montague fracture. What's Montague? This is the fracture of the upper third ulna, and in this condition there will be disruption of the annular ligament and dislocation of the radial head. So there's fracture upper third of the ulna with radial head dislocation, and mostly there will be annular ligament disruption. Very important to know the ligament which will be disrupted. Of course, we are doing the anteroposterior and lateral view to detect the type of the fracture according to what's called Bado classification. Bado classification had classified this type into four types. Type 1, in which the head of the radius is displaced anteriorly. Type 2, the head of the radius is displaced posteriorly. Type 3, the head of the radius is displaced laterally. This means in the coronal plane. And in type 4, both of the bones are dislocated, or are fractured with the presence of the anterior displacement of the head of the radius. So, in the case of the type 4, there will be fracture of both bones proximal or upper third, fracture of forearm with radial head anterior displacement. How can we manage this? You can see here According to the management, it must be managed immediately with the assessment of the radial head position, of course, after fixation, assessment of the radial head position. If reduced and stable, then nothing. If unreduced, then we make open reduction of the radial head and then reconstruction of the annular ligament. And sometimes we are doing what's called radiocapitellar wire, where we can introduce wire through the capitulum of the humerus to the radial head to restore its position. Here you can see in this X-ray, there is open reduction of the ulna, fixed with plate, very important. Of course, in the children, we can do wires or pinning. And after this fixation, we are doing radial head assessment for its reduction. If the radial head is in place, is reduced and stable, there is nothing to be done. If unstable, so we are doing reconstruction of what's called annular ligament, which is very important. You can see here, this is the preoperative and this is the postoperative. This patient has fractured Monteglia, in which there's fracture of the ulna, and you can displace here. There's shorting of the ulna, there's overlapping of the middle third ulna, and it's transverse pattern fracture, and it's displaced anteriorly. This is what's called anterior displacement. I'm sorry, it's displaced posteriorly because we are describing the distal fragment, while the head radius is displaced anteriorly. In this condition, plating was done and radial head was replaced. At last, thank you, and I hope you'll get benefit of this subject. Thank you.